So we're going to talk about modeling recurrent events with competing risks and time-varying exposure in observational databases. The research question we were trying to answer is to look at the impact of pulmonary rehabilitation started within 90 days of discharge from a COPD hospitalization and its effect on cumulative rehospitalizations within 1 year. There are several important issues to consider, this being an observational database. One is that the treatment, that's pulmonary rehab, is a time-varying exposure that could be any time between the day of their discharge to 90 days after. And the outcome assessment also starts at the day of discharge up to 1 year. So there is an overlap between the two. And then patients are really sick, so they can have repeat rehospitalizations. And these are sick patients, so death is a competing risk in this cohort. And because this is an observational study, we have non-random nature of the exposure. So it requires some robust methods to answer our question. So we are going to try to answer this using a multi-state model, which is where the patients can be in several states once they discharge. So they discharge, once they discharge, there would be a group of patients who do not have any hospitalizations and we will survive for 1 year. And there will be one group of patients who will die without any rehospitalizations. There is one group that will get rehospitalized, but from that rehospitalization, they can either keep getting rehospitalized or they can die or survive to the 1 year. So we are going to model time to rehospitalization conditional on the current state with death as a competing risk using Cox regression method. Once we analyze that way, we see that we studied over 190,000 Medicare beneficiaries who were 66 years or older who were discharged in 2014 due to COPD, and then only 1.5% of them received pulmonary rehabilitation. And of these, 59% get rehospitalized 1 or more times within the year, compared to patients who do not receive any PR, but who get 66% rehospitalization rate. So if from the Cox models, in the multi-state models, we see that receiving PR is definitely protective and it reduces the risk of rehospitalization in 1 year with hazard ratios less than 1. And for the analysis in B and C, the sensitivity analysis we did, B is where we computed a propensity score, matched patients who were not treated, and looked at the same multi-state modeling to see how the rehospitalizations look. And among C is only restricted to those who survived 1 year. We wanted to see what's the rehospitalization within an year. And at 1 year from this figure, we see that on an average, patients who start PR have 0.9 readmissions were compared to 1.4 readmissions among those who never started PR. So summary is that when we have this complex mechanism of where the patients can be in different states, once they are discharged, we have to employ advanced methods such as multi-state models to assess how to see the effect of this treatment on the outcome. And we also have to handle the competing risk of death, which these models help us to do. And then because the PR is not a non-random, we have to do some sensitivity analyses to make sure that the results we are seeing are robust to these changes in the cohort. But however, from the propensity score match results we have, which attenuated towards null, we have to be a little more cautious in interpreting those, because these is where we are not looking at the follow-up time from discharge, but this follow-up time is when the day they start PR up to 1 year from there. So because they start at different times, the follow-up time can be very different. Thank you so much. Any questions, please? I cannot hear.
Sorry. Very nice talk, thank you. So we have a question from Rick Pilsner. What is the major barriers for patients to receive pulmonary rehab?
So the major barriers from our other research we've seen is that one is something to do with that we've been hearing is these are very sick patients. So once they discharge, There could be other things going on that they start late, and there is a lot of differences in the program, how the program is designed. Not everyone gets started on the program right away after the discharge. There is a time lag, and also insurance issues. They are only allowed a certain number of sessions. So once they complete those sessions, whether they can go back or not is a problem. And distance. So it also, we have seen that patients who live much closer to a facility that provides PR, they more often go to that place and compared to places that don't have PR places. No.
Great. We have a question from Liz Evans. Great methods. Can you tell us more about the propensity score matching process?
Sure. So first we built a logistic regression model to build to assess the propensity score. And so this is a non-parsimonious model. It was a huge model with all patient characteristics and some selected interactions. Once we get a propensity score, what we did was we took for each patient who started PR, we had to match from the no PR, that's a huge group for us, but from the no PR group, we had to have one patient who had a similar propensity to match. We also had an additional requirement that the person who is matching from the non-PR group would be alive at least as many days as when they started the PR. So for example, if a patient starts PR on day 60, then from the non-PR group, that patient should have similar propensity as well as should be alive day 60 or beyond. So we are losing patients who die before then.
Can I just follow up on that question, just to ask, because I did notice that the association was quite a bit weaker
Yes.
with the propensity matched cohort, the 0.85 versus 0.71. And I was just wondering if you know what were the influential variables in the propensity score that may have, resulted in the attenuation.
So the one biggest thing I think of is that the patients who are getting matched on actually had to survive as many days. And also these patients have a very high readmission rate. So any readmissions that happen before they start PR is, that is not even counted at all. So the timing when we are starting to compare this outcome is shifting quite a bit, not from the discharge, but probably like 1, 2, or 2.5 months out from the discharge. So, and the kind of patients that we matched on that are kind of similar. So these are several things that are moving this result actually.
Okay, and we have a question from Lindsay Russo. You mentioned the non-random nature of the PR assignment. Can you talk a bit more about that, i.e. the range of different types of assignments?
Oh, so what I'm trying to say is that this is not like an RCT where you randomize patients into treatment or control group. This is an observational study. So we just had to identify patients who started PR based on their billing codes that we find in the data set. And that we've just identified, they just had to have a charge for that billing code, whatever the CMS has assigned, like a G code or something, and they should have it billed for them in an outpatient or a clinical setting after their day of discharge, but within days 1 to 90 or 0 to 90. So we are only picking up patients who went to the PR or anything. So it's only for those who get that treatment. It is nobody is deciding on who gets. There is no task to pick up the pay.
Sorry to clarify, I think I just meant in terms of there must be a range of assignments that some people are having regular rehab, more regular rehab than others in terms of like frequency of how often they're coming in.
Oh, so what we've seen is that I think CMS allows them a session there are for a weekly dose of 3 sessions, and I think it's about 12-week treatment, so it is like 36 sessions. But on average, the median dosage we saw is that patients were completing like 9 sessions once they start. So it's quite variable actually.
see, do you think we have time for one more quick question? We have one from Brian Whitcomb. You talked about death as a competing risk. Can you talk about how commonly this occurred in the cohort, the potential impact of competing risk on estimates and their interpretation, and if you considered alternatives for competing risks survival analysis?
So this cohort, we saw that the 1-year mortality rate is about 20% in this cohort. So that was a big piece. So so patients who have one readmission and after that they die, it's like their contribution to the analysis is kind of different from patients who have one readmission and survive for 1 year. So that kind of impacts with the follow-up thing. That is the biggest reason we went with a multi-state model, because this is more like a counting process where we could see how many repeat admissions they had, and we can look at the start and end time and then really make that transition state for death as one of the nuisance things, when nuisance parameters, if it is in there, to estimate that. And there are quite several methods to assess competing risk. There is fine and gray, but the problem is that they only deal with time to first event. So it's either readmission or death, but our interest was in looking at recurrent events. And there is one more method called Anderson-Gill, which looks at recurrent events, but the problem is they don't deal with the competing risk of death. So death or readmission doesn't matter in that model.